Hello, everybody. Good evening from the Philippines. Good morning, good afternoon, wherever you are in the world. And welcome to our exciting panel today entitled Decolonizing Global Health, Dismantling Power Imbalances. I'm Renzo Guinto. I'm the Chief Planetary Doctor of PH Lab. I'm based in the Philippines. And I have the privilege of moderating this important and dynamic panel about decolonizing global health. As we probably all know, decolonizing global health has become a very popular, important topic, especially in the past 2 to 3 years. From hashtag decolonize global health to the avalanche of commentaries and articles about African research papers without African authors, or workplace discrimination in global health organizations, or the lasting colonial legacies that impede health systems from progressing around the world, especially in the global south. So many discussions. And today, our panel will be reflecting on these pressing issues, these questions, especially in the time of COVID-19. And we will also think about these issues in relation to issues around gender equality and women empowerment. And so we brought here with us, again, a very esteemed panel. And I'll just mention their names very briefly. I encourage our guests, our participants, to visit the website of the conference where you can find their amazing bios. Today we have Sarah Hawkes, the director of the Center for Gender and Global Health at the University College London. She's also the co-director of Global Health 50/50. We have Kumar, the president and CEO of Ipas. Tlaleng Mofokeng, also known as Dr. T. She is the newly appointed UN Special Rapporteur on the right to health. And of course, last but not the least, we have Nathalie Pambrun, who is the president of the Canadian Association of Midwives. And again, thank you to our panelists for being here with me in this conversation. Before I ask my first question, I just want to acknowledge the situation in which we're in, and usually these conversations, you have a senior strong man talking over women, but this time, in the spirit of decolonizing and gender equality, I just feel so privileged to be the one asking questions, learning from amazing women global health leaders, and really drawing the wisdom that you have from your experiences, your background. And so it's really a deep honor and privilege for me, being with these amazing panelists. So let me start by asking, the question and a broad question. What, from your perspective, could you share, what decolonizing global health, means to you, and what it has to do with women's leadership? Even the word decolonizing itself is heavily contested. People interpret it in many different ways. There's no consensus, or do we even need a consensus on what it really means? And so, who would like to start the ball rolling? What is, for you, decolonizing global health, and then in relation to issues around gender and women? Anyone can start. Anu, please.
Sure, I'm happy to take a stab at that. Well, first of all, thank you so much, Renzo, for this panel, and to the conference for inviting me, inviting these other panelists to have this conversation as part of this important event. I think this conversation is, as you say, quite timely. So for me, this term decolonizing health, really, it does link to the process of colonization, which is a process of domination and subjugation. It has political and economic manifestations, but it also has real physical and bodily ones, along with emotional and, I think, intellectual manifestations. Women's bodies were and continue to be sites for both domination and subjugation, and sometimes it's very cruel ways, but very often in manipulative or transactional ways. So I think for women, we have to really overcome centuries of patriarchal domination. But at the same time, I think it's important to differentiate between women and women's experiences. White women, women of color, Black women, lesbian, we all have very different experiences. And so we have to kind of unpack what we mean by women's leadership, along with unpacking what we mean by decolonizing health. I mean, my own example is kind of has been maybe relevant here. So I was born in India. I speak Hindi. I was raised in the United States. I've lived in many parts of the world. I have had the benefit truly of a world-class education, and now I'm the CEO of an international NGO. And yet I have faced discrimination and I have faced racism. And I've also perpetuated it and been complicit in a colonial mindset. So I don't think that it's a either or. I think that we all must kind of grapple with our own roles in both being colonized and colonizer in this global health space.
Thank you, Annie, for those initial remarks, and also for the reflexivity that you demonstrated by acknowledging both the discrimination you experience, but also in the process we might end up being neo-colonizers ourselves, perpetuating these long-standing power imbalances. Who would like to speak next? I saw Dr. T unmute.
Thanks, Renzo. And just carrying on with what Anu has started, I think it's so important. You can't do the work of decolonization of anti-racism without being honest about, root causes and the negative impacts of those oppressive systems. I think we have to analyze power systems. We have to talk about, who is seen to be deserving of to be on the table, right? Firstly, and secondly, to talk about the very nature of global health politics, sexual and reproductive health rights, right? And those politics that are based on gendered, sexualized, racialized acts of dominance that, vulnerable situations that make people vulnerable or marginalized, right? Further then makes these people have to navigate really difficult systems every day just to survive. And I think as someone who grew up in South Africa with the history of both colonialism and apartheid, right? I know firsthand as a child what it's like to grow up in a system, in a country, in a space physically that's not designed for you. Living and growing up in a Bantustan and inhaling tear gas and remembering those things at the age of 8 years. Those are real life experiences, and there are ways that they shape who we are. They shape how we present ourselves to the world and how the world sees us. So the call for decolonization has to be systemic. We have to realize that a lot of colonization, a lot of racism is embedded in many structures. It's embedded in many of the solutions and programming, unfortunately, that many of us are in charge of leading or conceptualizing. So the call is really much more, I think, for me, about introspecting as a global health community and not shying away from the very difficult questions around power and where power lies and the very systems of oppression that lead to negative outcomes and that, again, impact on the right to health.
Right, and later I will also would like to hear more about how the colonial lens will be beneficial or will contribute to your work as the new special rapporteur. Since you just mentioned again the very direct impact of these colonial manifestations of global health practice and policy to the achievement of the right to health. I want to bring in either Sarah or Nathalie to the conversation. Do you want to add something about, again, trying to kind of unpack what decolonizing global health means? Nathalie?
Sure. I think for me, I share really a lot of the similarities to what was shared already. I think it's just understanding the political nature of health and centering or rehistoricizing the experiences, whether it's within our organizations, and breaking some of those silences of the past. And so where we can make way for changing leadership, changing knowledge, elevating those underrepresented voices. So part of it is, making more space at the table, making space for civil society members, underrepresented people, people with less privilege. But I think not, it can be done in a tokenistic way sometimes, and like filling quotas. And it's not about that. It's about really truly allowing agenda setting, leading discussions, making decisions, controlling the funds, and determining what's needed in a specific context. So I think that essentially, decolonizing global health is also learning our history, right? And learning the history that was told and the history that took place. When I think about, 70 years ago, when the World Health Organization and the UN started, like who defined those fundamental rights for every human being? Who wasn't at the table? Probably initially most countries from the global South. Probably Indigenous people were not part of those discussions. And so I think we're spinning on its head where global health has mainly been a top-down, now north to south, led primarily by affluent, rich men. And so I think that what we're seeing now is an attempt to ensure that peoples and communities that have been previously underrepresented are better included. And this involves looking at the whole ecosystem. And I think global health has had difficulty addressing sort of the structural violence as a determinant of health. If you want to look at that idea of like dismantling your house and looking at those pieces that, contribute to how we've arrived where we've arrived. And those are difficult conversations, and they require a lot of critical thinking and a lot of understanding of where we've come from. And so I'm excited about seeing women, come into the dialogue, be part of the discussions, bring a gender lens to the work that needs to be happening. I feel like it's those kind of power imbalances that they're by design, and they're not unique to global health, but often health is the place where a lot of those inequities intersect.
Thank you for that. A lot of really important points. And when you said about the importance of learning global health history, two things that came to mind. One, are we actually learning global health history enough, for example, in schools of public health? Is it even part of the curriculum, right? We need to keep on asking that question. But number two, who writes the history? And you mentioned about having more women, female voices. What is the herstory of global health? If we're going to rewrite the history, or herstory rather, of global health, maybe it will be, or not maybe, surely, it will be a different, kind of narrative. And so, I think that's a very powerful insight. I want to ask also Sarah about, her insights on, again, this subject of decolonizing global health. And then, of course, in relation to, gender equality, which you've been advocating for and championing for many years. Sarah?
Yeah, thank you, Renzo, and apologies for dropping off. We've got more internet problems than I imagined we would have, and so forgive me if I'm about to repeat some of what Nathalie said, because I missed some of it. But I think what sounds like a really simple question, what does decolonizing global health mean to each and every one of us? Kind of as the value of coming last is to sort of be able to point out the commonalities. The challenge of coming last is to try and say something that hasn't already been said before. And I think, I suspect that all of us have some idea of some shared ideas about what the question of decolonization might mean in different contexts. I mean, I think it also, from the work that we've been doing for many years now, it does raise the question of what do we all mean by global health. I mean, I think that it's probably worth spending some time thinking about the two different parts of your question. But it seems to me, and certainly to try to bring together the parts of your question, which are what does this mean for women's leadership? It does seem to me that decolonization. There's a great sociologist here. I'm sitting in Cambridge in the UK, and there's a great sociologist in Cambridge, Dr. Ali Megji, who has talked about decolonization as an opportunity to first of all to recognize, so to recognize what has gone on, what's led us to where we are now, an opportunity to reassess, to actually understand what brought us to this point, and to, I think really importantly, to reimagine. That this provides us once you start to have these kinds of conversations, you can think not only what's gone wrong in the past and why have we ended up in the situation that we're in, but what do we want the world to look like moving forward? That this provides us with a kind of moment of opportunity to say, okay, we've started a discussion, and the purpose of the discussion, to quote a well-known phrase, it's not just to philosophize about the meaning of decolonization, but to actually identify strategies to bring down inequalities in the future, to reimagine a world of global health, or more widely, which is a much more equal and equitable world for everybody, irrespective of whichever kinds of characteristic we're concerned with. And I think the one additional thing I would say is that for me, I spend a lot of my life looking at the architecture of global health, somewhat at the history of global health, but very much at the politics of decision making within global health. And I think it's really, really important to see, from my perspective, it's really important to see a conversation of decolonization as one example of inequalities within very prevalent systems of inequalities and social injustice that are permeating the worlds that all of us inhabit. So when I look at the imperial domination of economic systems in place today, that also translate into imperialist knowledge systems, for example, and imperialist viewpoints about the distribution of opportunity in the world. I think that we shouldn't. I think that this is not to detract from the question of decolonization, but it's to see it in the context of all those other inequalities that are still in place today and that very much permeate the world of global health. I mean, I could talk about the kind of data that we collect, but I think the data that we collect shows the history of decolonization, but it also shows the power of imperial domination within the global health system today.
Yeah, thank you, Sarah, and again, very rich remarks that you've just given. We need to problematize even the term global health. I remember Richard Horton even asked in one commentary a few years back, he asked the question, is global health inherently colonialist? And if that's the case, is decolonizing it even the right question? And you're reminding us that we need to look at these bigger structures, capitalism, all the isms that are, they're all brothers, right? And they all need to be tackled, at the same time. But you also emphasize the need for strategy. We need to strategize. We need some, how to turn the rhetoric into really concrete actions. And I think the report of Global Health 50/50, and by the way, thank you for inviting me to join the advisory board of Global Health 50/50, which you just announced early this week. Really a deep personal privilege. In that 2020 report, you did not only just talk about gender inequalities in global health leadership. You also gave some really compelling numbers about, geographic, maldistribution. 85% of global health organizations are based in North America and Europe, which have, organizations which have a mandate to serve the global South or to address problems in the global South. So, really huge asymmetries. Why is this important? What are the consequences of not, changing, the global health architecture that you mentioned? And maybe you have some insights as to the how. WHO reform, long discussion for decades, and it's been incremental change, what we've been seeing for many years. Sarah, you can start.
Yeah, thanks, Renzo, and welcome to the GH 5050 collective family. It's fantastic to have you on board. So just really briefly, why did we look at why did we take a more intersectional lens to trying to understand the distribution of power and privilege? I mean, partly it's because of everything that my colleagues on this panel have already talked about, that none of us are just men or just women. We are this complex construct of all of these other representations of both inequality and privilege, depending on where we are in the world and where we've come from, and and who we are. And I think, one of the things that we were trying to capture was, well, what does a more intersectional lens of inequality actually look like? And it turns out it's actually remarkably difficult to move from the theories and the discourse and the framing of intersectionality to something that's measurable in a kind of tick box way. And so we ended up measuring nationality, educational privilege, because we think that that's actually really important, and I'll come to that in just a second, as well as gender and age. And perfectly, we see a global health system that is still very, very much based in what might be called the global north, particularly Europe and North America, and the leadership of those global health of the organizations in that global health system are predominantly male, predominantly from northern countries, and very, very much educated within the global north. And I just want to focus on that last bit as to why did we think that was important. We thought it was really important to capture that, because what we think that is leading to is a kind of institutional stasis in the system. You have everybody trained in the same places. I mean, literally, there were as many people in our sample who had been educated at that other university in the other Cambridge, where I'm not sitting, i.e. Harvard University.
I came from, and I want to acknowledge that.
So there were as many people educated at Harvard as every single university in all low and middle income countries combined. Now, I think that that's problematic, because I think it leads you to a certain way of thinking about the nature of the world and the set of solutions, and it privileges a certain kind of knowledge and a certain way of thinking about how you change things. And what it doesn't allow is a variety of voices and views and visions to come to the table. And so that's what we were trying to capture. We were trying to say, look, yes, it's really important to recognize that there are these inequalities based on gender, but look more widely across the global health system. And the reason you've got those statistics there is because of the history.
Right. Thank you very much, Sarah. I have a question for Anu, because, we've talked about this report, Global Health 5050, but there's also an article in Think Global Health that Anu authored, entitled White Supremacy in Global Health. I think it's the first article in Global Health that has white supremacy in the title. And so it actually, caught a lot of people's attention. Can you, share with us, speak to how, white supremacist culture manifests, in the field of global health. And again, what are the implications if we are not, putting a stop, to this, phenomenon, this issue. Anu?
Yes, thank you, Renzo. It's interesting that it was the first time that that phrase has been used. It seemed obvious to me that what we're seeing here in our global health sector is actually white supremacy, and perhaps that's a term that's, kind of in your face, very bold, but I think honest. So I think what Dr. T mentioned earlier about really facing the facts is important. So yeah, so how does white supremacy show up? I mean, I think, first of all, it's important to understand what white supremacy is. It's fundamentally really about assuming that whiteness is the pinnacle of human achievement, and that everything else is not just flawed, but unworthy, and dehumanized and abnormal. So it's big, and it's deep, and it's deeply embedded, I think, in all of us, because it's been around for literally hundreds of years, and we have all imbibed this ideology. So the highest expression of white supremacy then is white men. And I think what's also really important to realize about this ideology is that it can only be maintained through power. And that is an imbalance of power. And so, as I mentioned earlier, power takes on multiple forms. There's financial power, physical, intellectual, and women are all part of that, or part of the realm that needs to be kind of dominated, and over which power is imposed. So it's not that I think that white supremacy is particular to global health, and I think perhaps Sarah or Nathalie, one of my other panelists, mentioned this earlier. It's not that somehow global health is unique in or being, or particularly or especially racist. It's just that global health is not immune from racism and white supremacist culture, because we are part of this broader culture. So how does this show up? And thinking about it from a very high level way, but now thinking about it from a more practical kind of level, how does it show up? And so I'm just going to mention a few things here, but by no means is this exhaustive. I think something that Sarah just mentioned, the lack of representation in leadership, it continues to be a real issue. Not just the limited number of women, but there are still very few women in leadership roles. And what I mean by leadership roles, I mean top leadership roles, including CEOs and boards of directors. But there's a dearth of women of color, and particularly Black women in top leadership roles. So, according to a survey in the UK, of UK international NGOs, 70% of staff are women, and yet only 30% of them actually reach the top of the organization. And this is not, unique or surprising. In the private sector, in the US, there are more CEOs named John leading Fortune 500 companies than there are women. Sort of similar to Sarah's point about Harvard, there are probably more Harvard-trained CEOs than there are women CEOs. So that's one thing. Just sort of lack of representation it continues to be an issue despite the many years of focus on diversity and equity and inclusion. And I think we have to acknowledge that those efforts have really been extremely limited in their impact. So that leads me to my second point, which is around discriminatory practices and policies. So, these are the policies that are embedded in an organization, things like recruitment, hiring, retention, staff development, promotions, all of the policies that really make up an organization need to be examined from this lens, from a white supremacist lens, and thought through again. The third aspect that I see is, trivializing local knowledge. Again, I think this was brought up by one of my other panelists. The kinds of knowledge that is privileged is a very particular kind of knowledge. The kind of data and research that is taken seriously is a very specific kind of data and research. And I also want to mention here that in the development and global health sector, we have a very obtuse language. I've been doing this work for a long time, and there are many times where I find myself unsure about what is being said, because the language that is being used, particularly by sort of the technocrats in our field, is really challenging, filled with jargon, very difficult to follow. And then the final thing I would say in terms of how we really need to think about white supremacy in the global health space is financial flows. And I think Nathalie mentioned donors and funding. I think the financial flows that come from northern countries to southern countries comes with many strings and many demands. And I think what I'm calling for is a significant change in the aid architecture, which over the long term could have many significant implications for international NGOs and donor agencies. I also think that it must be said that this would also demand more from southern countries, from less resourced countries, and that they also would need to step up if if they take global health, if they take health of their people seriously, then they must also invest in it, and that would require reducing the dependence on the aid that's being offered, which comes with strings, as we know. So I'll stop there. Thank you, Renzo.
Thank you so much, Anu. A lot of really, practical, tips. For instance, when you referred to, really, interrogating the language, the vocabulary that we use in global health. I can sense that in the conversation so far, we hesitated a bit, when we say words like global north, global south. These have, deep colonial baggage, and we still use them in, our Lancet editorials or, our reports. And then the other thing that you mentioned is about representation. And, one thing that is so practical and so concrete is that I think in the 21st century, there should be no room for not just Manels, all male panels, but also Hicanels, high income country panels, and Wanels, white panels, all talking about issues confronting the global south. And so our conversation now is the total antithesis of, a Manel, a Hicanel, and a Wanel. So, really simple things that we can do, even in the way we convene, the way we have these conversations in global health. But maybe some people are asking, okay, let's change workplace practices. Let's, bring in more, people, to the table. But how can we go beyond the cosmetic? And I want to bring in Nathalie, because I know you've been working and advocating for the restoration of Indigenous midwifery practices. And one of the important areas also of the decolonizing discourse is how can we actually amplify these Indigenous knowledge, wisdom, that there's not just one way of knowing, no single epistemology, but many, the word that they always use is this idea of pluralistic, right? Sorry for the tongue twister, pluralistic or pluriversal, that's another term, approach. What are the challenges now that you're seeing in your work, and how do you think we can, raise Indigenous thinking, make it, be part of mainstream global health conversation, and even use those, ancient wisdom, for instance, to really question, what we might, describe as a Western-centric notion of health and health system and global health, all these concepts that we use in our enterprise. Nathalie?
Thank you. I think in the Canadian context, just talking about situating myself here first, the persistent growth of Aboriginal health inequities is really signaling that we're at this kind of critical juncture in public health policy. And again, it's the policy that reflects the historic relationship between Aboriginal people in Canada that is essentially continuing to fail the contemporary health needs. And so really looking at we need to look at public health policy in a way that recognizes and prioritizes the rights of Aboriginal people to sort of achieve those inequities. And, you know, some of the barriers that are present at the moment is, you know, there is systemic poverty and disproportionate prevalence of chronic illness in our communities. We have underfunded health care services and a lack of basic infrastructure like clean water and overcrowded housing. But also there's a huge lack of healthcare governance. And so when you sort of speak to that piece about honoring different ways of knowing and doing, part of it for us as Indigenous people is reconnecting with those Indigenous knowledge systems and understanding what were our own Indigenous laws, our own Indigenous ways of doing. And so I think part of it is connecting that and then making sense of how we can transform sort of the landscape like going forward. Some of things that we see is that in my field of reproductive health is just these existing health outcomes for Indigenous people, like pregnant people and their babes are like, you know, the maternal mortality and morbidity is at least like 2 to 4 times higher in our communities. And so I think that part of it is really the capacity is there within our communities to address some of these issues, but what we need to do is build the local structures and systems where we're able to facilitate that capacity. And I think that midwives are gaining a lot of ground in Canada here. Part of that, I think, has been due to partnership with the Canadian Association of Midwives. I would say looking at the modality for transformation from an association standpoint is something that's very powerful because you're taking clinicians who have the on-the-ground knowledge, who are closest to those communities and their ability to impact health and impact policy change. And so that's been one way that the National Aboriginal Council of Midwives has been working with the Canadian Association of Midwives to see some of that transformation happen. And so what we're seeing is that Indigenous midwives do have a seat at the table. We've just been recently invited by ministers to address racism experienced by Indigenous people in our healthcare system. We're chairing committees on Indigenous women's health that involve multiple departments, and we're the only health professional outside of the Indigenous organizations that are leading these discussions. And so I think our expertise is really being recognized, it's being sought. And so I think it needs to happen at all the layers. And a big part of what we're doing is investing time in Indigenous communities and those who want to bring birth back and build those capacities, going into community, helping them understand everything from to be doing a reanalysis of what is going on, what could better the situation. And so I think it's happening at the grassroots level, and it has to happen at the policy levels, and somehow we bridge these together and they come together to like affect the change that we need.
Thank you so much, Nathalie. And that's a very important reminder. I think, you know, we in global health tend to, you know, focus on, you know, how many people are represented, for instance, in the halls of decision making, in the WHO, and, you know, this important global health organizations. But you are highlighting the importance of bottom-up approaches, strengthening communities, and really building the movement from ground up. Right? It cannot just be top-down technocratic approach. And that's how I want to bring Dr. T to the conversation, because, you know, she's been working with communities as a physician, but now she is the UN Special Rapporteur, who will be the, you know, the voice for the right to health for the whole world, but also, we know that the right to health is really a social movement, and we need, communities and people to get mobilized. So how do you see the colonial, conversation that is now evolving and developing? How do you see it contributing to your work as our new special rapporteur, especially in the time of a pandemic? Dr. T?
Oh.
No.
I think it's so important because the current context, COVID-19 has really, put a big spanner in the works here. But also in terms of understanding that the starting point is unequal and that systemic oppression lives and thrives within the systems that we navigate every day. And that not only do we deal with the context of COVID-19, but we also deal with health funding challenges, right? And COVID-19 has shown us that even at our best, as health systems globally and in the different regions, we were not prepared in terms of resourcing, in terms of planning, and being agile to respond and have, surplus funds and resources to respond to a pandemic, but also in terms of the global politics, in terms of the anti-gender, anti-critical race theory movement. It further underscores the importance of the work that we have to do and why we have to be intentional about this decolonial, anti-racist, and really understand the intersectional framework in the true sense of the word that Professor Kimberly Crenshaw, presented it to us. And it's about, recentering the marginalized and restoring dignity. And, the mandate of the Special Rapporteur, in fact, has been tasked with paying attention to situations of vulnerable and marginalized groups of people. And you can't do that, outside of an intersectional framework in the true sense of the word, because that then requires us to look at those systems that perpetuate dangerous or harmful gender stereotypes or norms, racial stereotypes that again are embedded in some of these programming and some of the research, for example. And then now, I always ask myself this question, whose voice counts, whose knowledge matters, and as someone who lives in an Africa region, I know, we often talk about the safari researchers, right? People come to South Africa, they spend a few weeks here, a few months, they go away back to their campuses in the global north, and they get their PhD or their master's, and they become the thought leaders of the global south and the experiences of the rest of us who are left behind, navigating these very difficult lived realities. And so it's exactly that question about whose knowledge counts. And I'm quite passionate about undergraduate medical training as well as nurse practitioner training, because I know even in my own experience as being a young medical student, I could notice colonialism and racism that's embedded even in how I was trained as a medical doctor, the types of the questions you are asking when you are taking a medical history. Some of them are making assumptions about being a young Black woman in Africa. So even the types of health products, reproductive health commodities, what you have access to, is operating within those power dynamics where medicine is very paternalistic, where patients are already disempowered by that imbalance in the consultation room, and therefore their ability to make informed decisions, their feeling of being affirmed and truly being holistically cared for is compromised by these different power dynamics. And so when you add a layer of socialization, right, that other identities, that other sexual orientations, that doesn't take into account issues that affect people who are disabled, people who have different language needs, it does create a problem. And if we are demonizing again, African knowledge and African health systems, It means that we will never get to a point where we have seamless referrals between indigenous knowledge or African health as well as the Western medicine health, because many people on the African continent, as well as other more developing countries, still rely on non-Western practitioners first. And it's only when there's surgery that's required or more invasive investigations that are required that people then move into the Western medicine. But I think it's the continuation of the othering, belittling, looking down on indigenous knowledge, as if it first needs to go through some institution in the global north, it gets repackaged and then sent back, to consume. Whereas if you look at the programs that some of the global, institutions are implementing across the regions of the world, they come with designs. People have decided what M&E frameworks is good for them. The imperialism around global funding and extending, political influence. It means that communities are always at loggerheads, right? People tell them what's priorities for their lives. And people tell them that, in fact, if you do 1, 2, 3, you will then have a better life. And people are not then empowered or even trusted, because the issue of trust is important, especially when you're talking about health and global health. And there is a lack of trust. And I think it's made worse by the lack of transparency, by the lack of accountability, by governments locally in the regions, but also as a global community that then has the economic capital and the money. And I think it's definitely an issue that we need to look at and talk about. Where does the power lie? And the fact that people are not inherently vulnerable or marginalized or poor. There are systems that continue to perpetuate those oppressive systemic problems that many people are facing. And so the right to health, right? The right of everyone to the enjoyment of the highest attainable physical and mental health depends on other systems working well. It depends on the economy working well, and women, right, and gender equality being expressed in the workplace, where women can come back for their results. Because we know in South Africa, a lot of women are dying still of cervical cancer, not because they don't know about screening. They come for screening, but they can't take time off again to come in queue for hours and hours just to get their results. So the time it takes for them to come back to XX services, sometimes life-saving services, is that much more longer because of policies in the workplace, because of unfair labor practices. So sometimes it may seem that the right to health is removed. But in fact, for me to succeed, I need all my other colleagues to succeed. Water and sanitation, right? Something as simple as preventing COVID-19 spread, directly impacting the right to health.
Yeah. Thank you, Dr. T. And we want you to succeed, and we want the right to health to succeed under your rapporteurship. And so, our whole gang here and all the others who are listening, tuning in, are with you. And thank you for laying out that kind of, radical approach that you will, that you plan to adopt as you tackle human rights issues as they relate to health. We have some questions, but we only have like 6 minutes. And so I want to give you a chance to actually give, some really, quick one-liner, powerful, reminders, messages, to our audience. But for example, we have one that has a question about, how can we break away from these archetypes of leadership? Especially it's harder for Black women to assume positions of leadership. Although Dr. T, you're the exact example, right? Of how those barriers can be overcome. So maybe you have some reflections on leadership for people of color, especially women. There's a question about how can we increase the capacity of global health, the sector, to really be not just rights-based, but also respectful of, indigenous communities' wisdom. We're not anymore paying lip service, to, again, tokenism, having an indigenous person around the table filled with old white, Ivy League educated men, right? So how can we really build our capacity and competency I guess, a decolonizing competency and capacity. And maybe, a final general question is, what's the way forward? Obviously, a 50-minute conversation about decolonizing global health is not enough, but, what is the next immediate step that we should take in order to move this forward? So who would like to start first? Dr. T, you're already unmuted, so please.
Oh, okay. So it's about, demanding a seat at the table. I think it's important for women's leadership, of course, to be heard. And I often make this example that it's not that, women don't speak up, or that women are not motivated. We are motivated. We do speak up, but we are not heard. Right. And that's the thing. And then it's that sometimes we may have to redesign the entire table altogether, because we may be fighting for a seat at the table, a table that was never designed for us in the first place. Right. And so it's about thinking beyond just wanting a seat at the table, and how we can be strategic in how we support each other across movements, and not work in silos. Because I think even if you look at the problems with global health right now, is that we people are working on different diseases, different disease profiles, different key populations, but no one is doing the work of weaving and threading the work together. And I think that's what's important. And I think that's why, having grassroots movements, regional movements that are run and led by women, resourced, is key. We need to resource women movements and women's leadership, and make sure that if they need to redesign the table, let them do so.
Thank you, Dr. T. Nathalie. And by the way, Nathalie, I forgot to acknowledge that this year is the year of midwives and nurses. So this is your year, but it's been, it's been a very an interesting and spectacular year for you because of the pandemic. But any final words related to, again, raising Indigenous voices?
I think just as I think the thing that rang so true for me was when Dr. T said, it's not just about having more seats at the table. It's so true. It is about creating the different, maybe the table needs like a whole other structure attached to it. I'm not sure. To allow for those different ways of knowing and doing to emerge. And I think that the intersectionality of our work, all of us, is where we're going to be able to find some of those solutions and bringing those movements together. And so I think that Indigenous voices are one piece of that, that have a lot to offer. And so we need to, figure out those structures that need to be in place that will allow all of us to have our voices and knowledge understood and best integrated for the health outcomes of everyone.
Thank you. Thank you. And who's next? Sarah? You only have 2 minutes.
Sure, Renzo. Perhaps I could just pick up on the issue of women's leadership, and how do we ensure equity in leadership. And I just have a couple of reflections on that really quickly. The first is that I think what we're actually trying to create is the knowledge that what we need is systemic change. This isn't just about changing who's at the top. You need to start you need to start even before people get into an organization. You need equity and equality in terms of who gets their foot in the door, let alone whether they rise to a position of leadership. And that, I think, that there's an element that foot in the door requires equitable leadership to get started, but it also requires trade union movements and workplace organization. It requires a lot of cohesion within the workplace itself. The second thing is, and I think COVID has really shown this absolutely acutely, is that we can all be as equal as we want to be within the workplace if we, go back to that reimagining the world that we want to see. But actually, when we step foot outside the workplace, if we've also got to go home and look after the kids, take care of the elderly, pick up where the schools are no longer able to do it because the children are all being homeschooled, etc., 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 then we are never going to achieve equality in the workplace until we have equality outside the workplace, including in the domestic sphere as well.
Thank you, Sarah. And final words from Anu. Oops, Anu, your microphone.
Like I said, the tagline for 2020, you're on mute.
You're unmuted.
So I just wanted to, it's one final thing. I think one of the really most insidious things about colonialism and about what we've been thinking about right now is that it encourages dichotomous thinking. So if the world is white and non-white, then there's a multitude that's hidden in those categories. If the world is male or female, only a dichotomous variable, then sexuality is not a continuum. So I think it's really important for us to recognize that the divide and conquer strategy is very strategic and it's very effective. It limits our vision. It keeps us fighting amongst ourselves for resources and other aspects of resource mobilization, and rather than actually thinking about the bigger picture, of well-being, of justice. We can't achieve any of those things. We can't achieve well-being and health, as Dr. T and others have been saying, without really paying attention to all aspects of our lives, frankly: gender justice, economic justice, climate justice, and racial justice, and much more. So I think resisting dichotomous thinking is really hard, but also really important.
Thank you so much, Anu. Thank you to our amazing panel for all your nuggets of wisdom. And I just want to close by reading what I shared with Global Health 50/50 when they actually, introduced me as a new member of their advisory council. Colonialist global health is also gender discriminatory, and therefore the pursuit of decolonizing global health cannot be totally divorced from the fight against gender inequality. And that a truly decolonized global health is global health 50/50. Thank you very much for tuning in, for joining us in this amazing conversation. It doesn't end here, and please stay safe. Goodbye.